So in MPS, the nervous system involvement, so what we see, so these are the neuropsychological problems, and I said that I would skip that. The only thing is about, and it was mentioned by Jan in the MPS, talking about MPS 3s. So we see there are some things that are quite typical. We see the echolalia, we see the impairment of the higher cognitive functions like agnostic functions like praxia and so on. But it's really hard to assess because of the speech problems. Those patients, they are not able to express themselves, and so we are not able to assess agnosis or asterognosis or graphesthesia and things like that, and these things are impaired, but we are not able to assess it. Also, the apraxia was mentioned. So the way to, well, those Sanfilippo patients, they are able to do certain movement, they are able to complete it, but if we ask them to do it, they are not able to complete it. So there's apraxia. There are different types of apraxia, and we looked at it closely when we did the trials for Shire with SEN-A and SEN-B, and it's not apraxia per se, because then they are able to do it spontaneously. Like if I ask them, okay, show me, and if they have still like some perception of the language, so show me how you brush your teeth or how you brush your hair. So if they have some perception, they are able to do it. But then if I ask them, or if I show them to do that, and also Jan, he mentioned that, so if I show them like do this or do that, just hit the table repeatedly, that's the problem. They are not able to do it. So it's not apraxia, it's the problem of imitation. And as a consequence, it's a problem of learning. But it's, we can see it like very early, then other things come up, and we are not able to assess these things. So that there is that problem of imitation. That's what we have noticed in the SEN-A and SEN-B patients. So then there are other cognitive deficits, behavioral disturbances. Again, I will not talk about restlessness and all things that we see in MPS, severe MPS 2, severe and MPS 3. Epilepsy will be addressed in the next talk. Sleep disturbances in MPS 1 that are linked to mechanical issues in the airways, or MPS 2, severe MPS 2, and MPS 3 that are linked to CNS, so that will be addressed in the next talk. Swallowing difficulties. It's another problem, and that's a topic for follow-up discussion. And what is the problem with that? There's macroglossia, there are mechanical things, but is there a CNS involvement in the swallowing issue? So that's I can give you an answer, and that's something that we can follow up and have a discussion about it. The same thing about incontinence. So we know that there is a problem with the training, the toilet training, the use of toilet, and so on, and also diarrhea. Is it in MPS 3? So is it a problem that is neurological? Is there a problem with the plexus in the gut, that there's a diarrhea in MPS 3? Again, something that is open for the discussion after the talk. So the nervous system involvement per se. So we see in MPS 1 and 2 and 6. We see that there is a peripheral nervous system involvement. It's the impingement syndrome. So it's the carpal tunnel and so on. And I will not talk about it because it does affect cognition. If we took all these peripheral somatic symptoms all together, the somatic burden, it affects cognition because those folks are limited. They move less, and it affects their cognition. But I will not talk about it because it's a secondary thing, and I think it's something that we need to address in future, especially as we mentioned here, talking about those kids surviving and getting to adulthood. So these are the things that we might be addressing in future in this population. Hearing and vision, that's another issue. Again, the hearing is affected in most of the patients. It's usually due in MPS 1 due to mediotitis, so there's inflammation. Partly there is also so it's a conductive problem, but there's also the nerve can be there can be the nerve involvement. But again, I'm skipping this topic, and we can address it in the discussion. The same with vision. I will not talk about corneal clouding, but the retinitis pigmentosa, which is a neurodegeneration of retina, that's one of the things that we can see in the later stages in MPS 3 or severe MPS 2, and CNS. So central nervous system involvement. So what we often see is the spinal cord related issues. Again, it's not directly linked to the cognition. It may be through the problems. If you have if there is a spinal cord injury, so it affects many things, locomotion. It affects. It can affect diaphragm. So the diaphragm. So it can lead to hypoventilation during sleep, and so on and so on. Again, I will not go more to the detail about the spinal cord impression and move to other topics that are more relevant to cognition. Cortical spinal tract involvement, again, it relates to spinal cord, but also in the late stages of the disease, especially in severe MPS 2 or MPS 3, we see the spasticity, which is the result of the cortical spinal tract involvement. I believe it's because of the neurodegeneration in the brain, so it's at the very beginning of the cortical spinal tract. And I remember in one of the papers about Sanfilippo, so they mentioned 50% of patients having spasticity. It can be assessed by the scale that is used in physiotherapy, the Ashworth scale, and then also the loss of the muscle strength can be assessed with the muscle grip test and the muscle test. So that's one of the things how we can assess it. Again, do we need to assess it? Well, it's something that comes in the later stage of the disease. We can assess such things if we are talking about MPS and spinal cord, but in MPS 3, in those late stages of the disease, I don't think it's something that we need to assess unless we are describing entire picture of the given patient or of the given MPS unit. Higher cognitive functions, they were mentioned by neuropsychologists. So cerebellar syndrome. Cerebellum, it is affected in animals. It is affected in dogs. It is affected in mice, in mouse models. We don't see much, at least as far as I know, in MPS, in any type of MPS. And also in MRI studies, I'm still looking at it, but in MPS 3, that's a hallmark of MPS 3 in animals. In dogs, mouse, we don't see much. And clinically, we don't see it. We don't see it at all. We see the gait is affected in MPS 3. It's because of the weakness. It's because of the cortical spinal tract, of spasticity, and maybe apraxia of the gait, but not the cerebral syndrome. Parkinsonian syndrome, the same as, so again, we don't see it, but there are some links of the Parkinsonian syndrome, genetic links and pathological links, that were discussed in this paper published in Movement Disorders 4 years ago. So there's intracellular alpha-synuclein accumulation in the cerebral cortex. So that's one of the things we see in Parkinson's, and it was shown in 2 Sanfilippo A syndrome cases post-mortem, and by the PER7 staining. And there was shown an association between this anaglogene polymorphism and risk for Parkinson's disease. I think they looked at 1,000 Parkinson's disease patients and found that link. Well, it's MPS, it's not Gaucher disease, where we see the link really, and with the mutation, and it's known. But in MPS there are like some signs that there might be a link, at least at the pathophysiological, but clinically, no. And that's it. So I will open this topic for the discussion. It's not epilepsy, it's not sleep, it's coming. So if you have any questions, for me, I was just wondering, why is diarrhea in MPS 3? What is the cause of the swallowing difficulties? Then also, Jan, he mentioned, JP, I don't know if I should, Jan or JP, he mentioned the emotional problems that laughter and cry that come and go. Is it pseudobulbar? Is it what we see, for example, in ALS, in amyotrophic lateral sclerosis, where there is a frontal lobe frontal lobe atrophy with deliberation, and then we see those two symptoms can be controlled by medication. I don't think it's something that we really need to address in MPES. It's not the main symptom. But what do you think about pathophysiology of that? So these are just some questions I asked myself when I was preparing this talk, and this is open for discussion.
I think for diarrhea, we don't only see it in MPS 3, but also very much in MPS 2. And I always tend to explain it by involvement of the plexus. However, some patients go on a diet, and then it improves. Post of propter. I have no idea.
Yeah, for diarrhea, it's really very interesting. In the different subtypes of Sanfilippo, it seems to be, type A is more prevalent with the diarrhea than the type C. Personally, my son Jonah had very bad diarrhea, and he grew out of it. We do limit dairy quite a bit, and he is on Geniston, but I have no idea why he stopped having diarrhea, and a lot of kids eventually grow out of diarrhea. And then also back to the pseudopulbar effect that we discussed before in Stockholm as well. One of the main issues that really upsets a lot of the families is this chronic, hysterical screaming. And the screaming and the pacing back and forth, and the no sleeping, and taking these children to one doctor after the next, trying to figure out what it is. And we talked about in Stockholm, Nudexta and PBA, and I've spread the word, and it has had an effect with these families.
Well, you should publish that.
Well, I want one of you guys to publish it. I have been meaning to call the company. Nudexta for PBA, pseudopulbar effect, which you find a lot in Alzheimer's and Parkinson's and some MS, where it is chronic laughter, like hysterical laughter for no reason, and then hysterical crying as if they're in pain for no reason. And that's what scares families, is the crying.
And you saw an effect of these treatments?
Yes, these families have seen an effect, especially with the families that had the hysterical laughing.
Because I'm still not like 100% convinced it's pseudobulbar. I don't know, because I didn't look at it so closely. I know we talked about it, and then I saw it, and it's just that spastic. They call it spastic. They just suddenly start to laugh or cry, and I personally I saw it in a couple of Sanfilippo, but then I saw it also in as you say in a patient with spinobulbar syndrome, which is Kennedy disease. Well, I have to add that William Kennedy was at the University of Minnesota, like Sylvester Sanfilippo. So then I remember that, but then so again, it reacts? It works with the treatment, but is it pseudobulbar?
I don't know.
What do you think?
How are you going to find out?
You can find out.
I mean, it's not clear, but it's interesting that it is responsive to Nudexta, which is dextromethorphan, which is a cough medicine, and quinidine. It's a combination medicine that we use in the adult neurology world for pseudobulbar affective. We use it off-label. I mean, my movement disorder colleagues use it off-label for other neurodegenerative that leads to this emotional incontinence or this lability, or it's this inappropriate emotional response, whether it's positive or negative. So it's extremely interesting, and it should be looked at more closely. But can you correlate that? I'm not sure at this point. it's almost kind of using it as a indicator that it is pseudobulbar.
Right.
How specific is it? I'd have to look at the literature.
Well, the one way how to examine is like you can look at the masseter reflux, and it should be increased.
The 5-5, right? So
Yeah, and you would have like.
But how do you get them to relax enough so you can elicit a proper, reflex in that sense?
Right.
It should be looked at. It's very interesting to hear that there is a response that should be formally researched.
No, you can tell the generic name because I think it doesn't.
Yeah, new Dexter.
No, it's the.
And quinidine together.
Quantity.
Quinidine and dextromethorphan, which is a cough medicine, and quinidine, which is an old, very old.
But dextromethorphan, I think in big dosages also does something with your neurotransmitters, and that is why it is used in other metabolic disease. Non-catalytic, yeah, exactly, yes. So it might be something on that.
I don't know if this is totally appropriate, but I do have lots of videos on my computer if anybody's interested that I do have permission to share.
Okay, excellent. So I think it might be a good case report, and then and write it down, and that people can read it and use it for their patients. It's very good. Steve Holland has a question.
I was just going to add that my MPS I daughter is in various forms of psychiatric conditions, one of which has been the extreme laughter and extreme crying. So she's verbal, so we can learn more. So it may be some tie-in between the syndromes, where she's able to tell us more about it in the symphony.
We've also seen it in this one.
I'm sure it's looked at, but just also know that gelastic seizures are also cause an outburst of laughter. So that's a type of seizure that. But that's not pretty much seen in this. We don't see it, but it's interesting. But they're deep. It's a deep phenomenon, so maybe you miss it. I don't know, right? It's deep gray. It's a hypothalamic mediated, so maybe you're missing it because remember we're only doing cortical leads. So that was a question of mine for the community is, I don't do the epilepsy constantly, but.
One more question.
There's a couple of points I wanted to make in addition. Maybe I'll add a third, because I think quite often we call that outbursts of laughter. We have categorized it as scholastic seizures and treated with epilim or tegretol, which are both successful, although they are mood-changing drugs. So by what technique, I don't know, but they do help also. I was going to mention about, you said Parkinsonism, we don't see it. I wonder myself, do I look hard enough? Because I think back to some of the older children, and do we really scrutinize them, or have we really examined them carefully enough to be sure? And thinking about how some of their gait, the difficulty in initiating gait, some impassivity of facial movement. So I do wonder whether there is interest in looking at neurotransmitters. It may be a secondary phenomenon, but I feel I wouldn't be so certain that there's no Parkinsonian features in the children I've seen. And on the gut, I think it's not simply diarrhea, it's a gut dysmotility. And we've seen a lot of children with neurological gastric distension and difficult, I know, to the extent where they were unfeedable by enteral. That's seen both in late onset Hunter and in Sanfilippo. So I do think it's a neurological gut dysmotility syndrome.
Thank you. I agree that I don't think it's being looked at and I believe it's in advanced stages of Sanfilippo, for example, where we can see the hypomimia maybe, and then the gait initiation. The gait initiation, it can be tricky because it can be also that apraxia. So, I would go with the signs of Parkinsonism as tremor, rigidity, and what else there? And akinesia, hypokinesia. Thank you. And there's that fourth. I think is autonomic stuff. So yeah, I don't think it's being looked at. And again, like a lot of things, they are not being looked at because they are not super important, like to be addressed. And then also for the neurotransmitter studies, I don't know how it is in Europe. In the US, probably we wouldn't be able to do SPECT or PET study. IRB wouldn't allow it to do it, to find out if there is any neurotransmitter problem. Right, but if you want to look at the, if you want to look if there's like if there's something going on in the stratum, and if there's like a lack of dopamine uptake and stuff like that, so then probably we would need to do something like that. But again, I don't think it's super relevant for the quality of life of those patients to know. Even, probably the easiest would be like to try levodopa and to see, if.
When we look to slow progression patients that they're about 30 years, we have one of 48 and she's still walking and she doesn't have Parkinsonism, she's a Sanfilippo A, and the sister is nearly the same and she's 32, and then we don't see any Parkinsonism. What we see is a slowly progressive dementia, and when dementia appears, spasticity appears and everything goes down like other disease. And another thing is that for the diarrhea, if you use loperamide, it's quite good for them.
Imodium, like Imodium, AD. So I just. Yeah. Yeah, and I just, actually, you mentioned DOPA. I have 2 MPS 3D. I know we're talking about A and B. And one of the siblings started to have a gait problem. And I took off the shoe and had him walk, and I stressed the gait, and he actually had a dystonic foot posture. And I put him on DOPA, and it responded. But it was an interesting one-off. So if anyone else hears about it, he's 10.
Well, there are also if it was dystonia, so there are other there is levodopa responsive dystonia, which is like worse. I think there's like some circadian rhythm and it's worse. I know in the evening or in the morning, and it responds really well to dopa. Well, thank you. That was great. So let's move to epilepsy really quick.